بتاعنا الجيل الصاعد دكتورة نهال كمال. ونهال كمال اسمها يعني فني، يعني زوجة المرحوم الشاعر العظيم عبد الرحمن المنوني، فبدعوها انها يعني تقول لنا قصيده من الحاجات الشهيره.
يا ريت.
اتفضل دكتوره نهال كمال.
مش قصدي حاجه خالص It's a pleasure to be here and presenting my case to you in this conference. I hope a wonderful and successful conference in our case presentation. My name is Nehal Kamal, resident at Rheumatology and Rehabilitation at Mansoura University. A 7-year-old girl complaining from pain and swelling in both knees, fever and abdominal pain 1 year ago. In May 2017, the patient presented to our pediatric rheumatology clinic by pain and swelling of both wrist and knees with morning stiffness more than 1 hour. Here, examination revealed bilateral symmetrical body arthritis of both wrist, elbows, and knees, no fever or skin rashes, with markedly elevated acute phase reactant, negative autoimmune antibodies, ASO, and virology, with normal serum ferritin level. Accordingly, the patient was diagnosed as rheumatoid factor negative polyarticular GIA. The following therapy was started: prednisolone 7.5 mg per day, methotrexate 10 mg per week, folic acid 5 mg once per week. With a good remission within 4 weeks, then gradual withdrawal of steroid until stopping it. Follow-up in our pediatric rheumatology clinic. The patient showed a good remission with evidence of mild residual arthritis in both knees. At March 2018, the patient presented in our OBC with high-grade fever, diffuse abdominal pain, mild swelling of both knees. The patient was admitted, and when admitted, she had a high-grade fever up to 40 degrees Celsius. This fever was continuous without any spikes, lasting for 48 hours, not responding to antibiotic, associated with generalized abdominal pain, not responding to antispasmodic, not associated with constipation or diarrhea, no nausea, vomiting, or jaundice, no symptoms suggestive of respiratory, genitourinary, or other system involvement, no night sweating, no history of recent weight loss. The patient appeared ill, conscious, oriented to time-place persons with average height and weight, vital signs showing high-grade fever, 39 degrees Celsius, with tachycardia and tachypnea, no cyanosis, pallor, or jaundice, no lower limb edema, no palmar lymph node. Musculoskeletal examination showed only mild arthritis of both knees, other joints were free. Abdominal examination, diffuse tenderness, no hepatosplenomegaly, no ascites. Chest and cardiovascular exam were free. Dermatological examination were also free. Here, CBC show microcytic hypochromic anemia and highly elevated acute phase reactant with normal liver and kidney function, normal serum ferritin level. ASO was negative, virology profile was negative, blood culture, tuberculin test, VDAT test, varicella were also negative. Stool analysis and urine analysis free. Occult blood in stool was negative. Here, abdominal ultrasound free was with no hepatosplenomegaly. Medication during admission. Patient already was on regular treatment for hair arthritis, methotrexate 10 mg per week, folic acid. Broad broad-spectrum antibiotic, analgesic, and antibiotic were also given without any response for the first 2 days. Then complete remission of the fever and GIT symptoms occurred. Patient was under observation for 3 days and discharged. On follow-up, the patient experienced several attacks. These episodes of high-grade fever and generalized abdominal pain came once per week, 3 attacks in the following months. Not associated with exacerbation of the mild persistent arthritis of both knees nor other joint involvement. Differential diagnosis: systemic GIA, the fever not spiking, no exacerbation of arthritis during the fever, no rash, no lymphadenopathy, nor hepatosplenomegaly, normal level of serum creatine. So it is excluded. Rheumatic fever, patient underwent tonsillectomy at the age of 3 years with no history of recurrent pharyngitis. The arthritis not migratory, ASO within normal range. So it's also excluded. Infection, no diarrhea or tenesmus, no dysuria, no cough, crepitation, normal stool and urine analysis, negative virology profile and blood culture, Vidal, Bolocella, and Spurkin tests were negative, also excluded. Malignancy, as leukemia and lymphoma, no systemic manifestation, marked weight loss, no night sweating, no lymphadenopathy, nor hepatosplenomegaly, normal CBC count, normal serum creatine level, so also excluded. Systemic lupus, erythematosus, no oral ulcer, alopecia, no marrow rash, ANA negative and double-strand DNA negative, also excluded. Inflammatory bowel disease, ulcers or Crohn's, no oral ulcer, no attacks of diarrhea, nor constipation, occult blood in stool was negative, excluded. Autoinflammatory disease as FMF, recurrent episode of high-grade fever with generalized abdominal pain coming in attacks lasting for 48 hours. On revision of hair family history revealed 4th-degree relatives with FMF, two of her cousins. MELV gene was found. Patient is positive heterozygous mutation for M694-5 for MEF gene. As regarding autoinflammatory disease, FMF, patient fulfilled erythema criteria 2009 for FMF, fever, abdominal pain, family history of FMF. So the diagnosis was overlap FMF with rheumatoid factor negative polyarticular GIA. According to the recommendation for management of FMF, Colchicine 0.5 mg 1 tablet per day was added, showing the dramatic response as the episodes were successfully prevented. On subsequent follow-up in our OPD, the attacks of fever and abdominal pain disappeared since 1 year, normalization of hair acute phase reactant, ESR 10 and CRP 6. These are case reports showing severe outcome of juvenile GIA, juvenile idiopathic arthritis associated with FMF. As a long-term follow-up, the first one developed total joint replacement due to osteonecrosis, also repeated ileal obstruction, and amyloidosis, which resulted in renal failure and fertility, and then died at 42 years. The second and third developed underwent bilateral hip replacement due to severe erosive polyarthritis. So aggressive treatment is indicated when GIA and FMF coexist. This table shows ELA recommendation for management of FMF. Some important points: compliant patient not responding to maximum tolerated dose of colchicine alternative biology are indicated in this patient. FMF treatment needs to be intensified in AA amyloidosis using the maximal tolerated dose of colchicine and supplemented with biologics as required. Response, toxicity, compliance should be monitored every 6 months. If liver enzymes are elevated greater than twofold, the colchicine should be reduced and the cause further investigated. Decreased renal function, the risk of toxicity is very high. Signs of colchicine toxicity as well as creatinine phosphokinase should be monitored and colchicine dose reduced accordingly. Colchicine shouldn't be discontinued during conception, pregnancy, or lactation. Chronic arthritis in patients with FMF might need DMARDs, intra-articular steroid injection, or biologics. If a patient is stable with no attacks for more than 5 years and no elevated acute phase reactant, dose reduction could be considered. This article shows successful treatment with anti-TNF of proteinuria in patients with FMF resistant to colchicine. Anti-TNF used infliximab and etanercept. And also anti-interleukin-1 treatment in FMF and related amyloidosis. They used anakinra and canakinumab. Also, this coexistence of FMF and GIA with osteoporosis successfully treated by etanercept. Thank you.